announcements? I've been listening in, and then hi, I'm Lilia. I'm actually with her. Yeah, same one. Yep. What about you guys? Like, every poll, I just got married. I'm kind of trying to get into my new name. I don't know if I'm okay. Oh, yeah. So, how are you? How are you? Because I had talked to her. Jim Prepper. So we've been having a discussion. All right, everybody, if you can go ahead and find some seats and grab a cup of coffee, we're going to get started here. I'm Kathy from Molina. Any minute now, we're totally ready to get started. Okay. All right, are we ready? On this glorious, glorious day outside, thank you all for coming inside. It's hard because we all know we've got this brief window of weather. We suffered through the heat and the smoke, and then we know that we have got who knows how much snow and cold coming. So we've got this brief window here in the region, and you're spending it inside with us. So thank you. We really appreciate that. I'm Jack Davies with the Northwest Rural Health Network. I'm the co-chair of the Better Health Together Leadership Council. And as always, we'd like to just start off very quickly and go around the room and do brief introductions. We're really liking the rounds this morning. We're seeing how much people are talking, which is great. In the middle of your tables are a microphone, so hopefully you don't have to pass it around like we have had at prior meetings, but hopefully the people on the phone will be able to hear us. And I'm going to surprise you and start around this end of the room. And if you could tell us your name and your organization. I'm Lilia. Actually, we've got just speak into the square thing there. Okay. I'm Lilia, and I'm from Operation Healthy Family. Excellent.
My name is Scott Elmo. I'm the Eastern Washington Social Service Coordinator for DSHS and the Community Service Group.
And let's go ahead and try to use this.
Okay.
Thanks.
Sure, do it with me. I'm Mike Midkiff with the Department of Social and Health for the eastern side of the state, and we cover all of the public assistance, Medicaid, and welfare to work programs.
I'm Paula Williams, Operation Healthy Family, and we provide dental access for those who are struggling. I'm going to pass it to Lilia, who's also with Operation Healthy Family, because you didn't hear her.
I'm Lilia. I'm also from Operation Healthy Family, and I'm actually the mayor provost stuff for them, so I'm helping build capacity for them.
Hi, I'm Jim Heilsberg. I'm with Better Health Together. I'm with the kind of finance and strategy.
Hi, good morning. I'm Kathy Olson from Molina Healthcare.
And I'm Misty Kutzman with Molina Healthcare.
Tammy Anderson, Merit Disability.
Christy Reyes, Spokane County Detention Services. Sharice Pope, Chief Business Officer for Excelsior.
Dan Sigler, Regional Director with Pioneer Human Services.
Kat Latte, Community Health Plan of Washington.
Ryan Kiley, Excelsior.
Nadine Vanstone, Epic Charities.
Keep you guessing which table I'm going to next.
Good morning. Tony Smith, Spokane Regional Health District.
Amina Sahaski, United Healthcare. Fawn Schott with Volunteers of America.
Good morning, Jerry Allard, Smile Spokane with the Oral Health Local Impact Network.
Sarah Bullock-Dorn, also with United Healthcare.
Hi, I'm Mike Weiser with Chaz Health.
Carol Plisky, Partners with Families and Children.
Lynn Kimball, Aging and Long-Term Care.
Jane Kendam, Aging and Long-Term Care.
Aruna Bhuta, Aging and Long-Term Care.
Joy Peltier, Planned Parenthood.
Terry Kosky, NAMI Spokane, National Alliance on Mental Illness.
Andrea Toll, Coordinated Care. Reese Holford with Pediatric Transforming Clinical Practice Initiative.
Dawn Sayers with Qualis Health.
Shannon McNamara Group.
Jenny Smith with Newport Hospital and Health Services, and also the Pondray Health Coalition.
Ron Poplowski, Healthcare Business Manager, Kalispell Tribe.
Cindy Hoberg, Community Health Plan of Washington.
Jenny Slagle, Better Health Together.
Hi, good morning. I'm Christine Canata with the Healthcare Authority.
And then we're gonna finish up here with Justin.
Good morning, Justin Bodishu here on Better Health Together.
And we've got a few folks online. And so, let's see, can you show me their names? All right. So we're gonna start with Betsy, if you could introduce yourself. And you might be muted. Betsy? All right. How about Blake? Oh, Betty's saying she's on her mind. Oh, not mine. Betsy is here. Blake, can you introduce yourself to the group?
Yeah, good morning. Blake McGrady, Executive Director of Spokane Treatment and Recovery Services.
Thank you. And Carly?
Hi, good morning, everyone. My name is Carly Levitz, and I am from the Center for Community Health and Evaluation.
Thank you. And Jim?
Hi, this is Jim Jackson. I'm the ACH liaison for the Department of Social and Health Services.
Thanks, Jim. And Libby?
I'm Libby Hine from Children's Home Society of Washington.
Great, thank you. And Maureen?
Hi, good morning, everyone. This is Maureen Finneran with the Arcora Foundation, formerly the Washington Dental Service Foundation.
Thank you. And Rick? Oh, Rick says hello all. He's got problems with his microphone. Thanks, Rick. Sandra?
This is Sandra Suarez, Yakima Valley Farmers Clinic Unified Community Health Centers.
Thank you. And is there anybody else online whose name I haven't called?
Yes, this is Julie Schultz from ESD 101.
Great, thanks, Julie. So, anybody else? All right, let's move on with our agenda. I think first up is Lynn Kimball.
Here's a clicker for you.
Okay. All right, so I wanted to let you know that Initiative 2 has gone live, so September 11th. We're all here today for Initiative 1 and Accountable Communities of Health, but there's 2 other parts to Medicaid transformation. So I just wanted to give you a quick, all right, what it is, how to refer, so that you know this one is going, it's live. What it is new services and supports for unpaid caregivers. So family caregivers, friends, those taking care of a loved one. They don't always see their role as caregiving, but a lot of times they're there and they're doing care and they need help. So this is really for individuals who really need some help and support in order to keep that caregiver in their role as a caregiver. So supports are available. Individual counseling, support groups, respite if people need a break, medical equipment, and more. Funding for this part of the waiver is done through Medicaid, but it is also for both people who currently qualify for Medicaid services as well as those who are not yet financially eligible for Medicaid. We also have state-funded services as well. If you have people to refer who don't quite fit either of those populations, there's a good chance we're able to serve them. Screening is done at the point of call, and I'll follow this with contact information. And persons who are 55 and older who don't currently have a caregiver, they're not yet financially eligible for Medicaid, they can actually get some limited supports and some personal care through this program as well. And I'll send around, we just got some new eligibility charts from the state yesterday, and I just got them this morning, so I'll pass that around as well so you have an idea of who qualifies. But know that if you're serving individuals in the community who are taking care of an older adult, maybe their own health is starting to struggle because of the caregiving role, maybe they need some extra support, there are services available. So please, please, please refer, because we will be ramping up these services over the next several years with the demonstration. So, you can do the next one. So in Spokane County, you can access services here through Elder Services, and the number is there in option 2. Rural Resources Community Action is doing these services in Ferry, Stevens, Pondere, and Whitman counties. And those of you from Adams and Lincoln County, note that you can also access these same services through Aging and Adult Care of Central Washington. If you're here with a statewide organization, you just have to look up who is your local area agency on aging. And if you go to agingwashington.org, you've got a directory right there of who you can refer people to. The nice part is we can do screening over the phone to figure out, does this person appear to be eligible or not? Start certain services immediately with that phone call, and then do some follow-up to do some longer-term services to help stabilize that person in the home and hopefully keep them from needing full Medicaid long-term care services. So with that, thank you very much.
Thanks, Lynn. That is awesome, exciting news to hear. I think this one came from you. That we finally got some. We're launching. Let's go. This has been a year of action. So, can I get that clicker? I have some other exciting news to share about Initiative 1 today, which most of you probably already heard in our either the press release or our weekly email. The PhD got $5 million in phase 2 certification. Woo-hoo! So it's a big relief for us. We felt really great, and all 9 ACHs across the state all got full earnings, so everyone got $5 million to sort of launch our planning for this work. I also want to say thank you to everyone a number of folks sent in letters of support, or the folks who filled out the health systems inventory and the care coordination inventory. That information was really helpful in us demonstrating to the healthcare authority that we had support, we had the right number of Medicaid beneficiaries through the partners we've been engaging. So just thanks for your help in our success in this. Today I want to start out our meeting with a little activity to actually go through the scores that we received for on this certification and kind of get some feedback from you all on the areas where we were weaker. I'd like to know from you all both how you think we're doing and sort of your interpretation of the comments we got from the healthcare authority, and also hear some suggestions about how we might improve or what we could show the healthcare authority differently as we ramp up for what we're calling phase 3 certification, which is the project application that will be due in November to the healthcare authority. A lot of that is a really similar narrative, just expanding on what we had to write for phase 2. So there's an opportunity where we heard that maybe the healthcare authority had some questions, or they thought we were weak on something, that we can use this time to boost ourselves up and increase our chances for a really successful application in November. So the process, it was a long narrative. It was all just a narrative application. There was a very limited word count, so I will say that internally we struggled to figure out what was the most important thing and what was worth showing when we were really limited in how much room we had to describe everything. Scoring, the certifications were all scored by an independent assessor, and we were given a feedback sheet that included a list of where we had any deficiencies in our answers. So what we're going to go through today is the scores where we had, so here's our scoring. Overall, all the ACHs received within the 90% range, so between 90 and 100, which earned them the $5 million. We had, strong showing in our transformation project planning, in our data, budget, governance, so I feel like our infrastructure is solid and how we plan to approach this work. We got approval from the Healthcare Authority that's looking good and on track. Where we saw we were a little weaker was in tribal engagement collaboration, in clinical capacity and engagement, and also in community and stakeholder engagement. We lost a point here in theory of action. The comments that we were given were that the Healthcare Authority didn't see how in our theory of action that it translated to population improvement outside of the Medicaid demonstration. And I think we see really clearly in the narrative where we could have increased, we could have put some more words towards that to make it clear that we see a lot of ways that this work is going to be much broader. We don't think any of this is happening just to the Medicaid population. There are systems changes that are going to improve care and improve delivery for everyone in the whole system. And I feel more like it was a weakness in our writing than it was the Healthcare Authority not understanding what we did there. So today I'm just going to focus on the other three where we had lower scores. So what I have today is we'll go through the comments that we received from the Healthcare Authority. Everyone on your tables has a piece of paper that looks like this. It includes the comments, gotta stay away from the mic. It includes the comments that we received from the Healthcare Authority, as well as space for 2 questions. So I'm hoping that we can spend the next half an hour or so in our small group tables looking at these, looking at the deficiencies that they called out and addressing 2 main questions. So first of all, what I want to know is, as you read the comment, so this is what Healthcare Authority, well, the independent assessor selected by Healthcare Authority said they felt like our application was deficient in. And let us know how this feels to you. Like, does this seem true that you would agree that it's an area that we can improve, or that you haven't seen this demonstrated by VHT? Or do you feel like there is a place where you've seen it done well? Any of your reactions as a table, if you can write those down for us, this is going to help me understand where was it that maybe we really are weak, or where is it that we didn't boost up our narrative enough to really communicate that we might be doing better than it was perceived. The second question that I'm looking for is just very simple. What would you like to see VHT do? Now that you're hearing these comments and knowing that we have time to ramp up for this next application round, what would you like to actually see us do in order to sort of meet whatever it is that the assessors commented on? So how can we make an improvement? Is there something that we could put into practice right away that could help by the time we get to November? Or is there something we could communicate differently? Like, how do you think that, I'm eager for your ideas on how we could improve. So that's the overall framework. For folks on the phone, we're going to do our breakout session where we mute everyone in the room so you can't hear them and we can't hear you, and you'll be able to talk amongst the other folks on the phone. We're going to put in the chat box a link to a SurveyMonkey, which has the exact same form that the folks in the room have, so you can go ahead and fill it out electronically and then just hit send and we'll be able to receive your comments. We're also going to let that SurveyMonkey link go live after this meeting, so if the folks who weren't here, they'll get the same form and they can also give us comments. Also on your tables, everyone has 2 pieces of paper with a list of the questions that were actually asked for these sections, so you can see what it is we were asked to answer. I know it might be kind of hard without having read Phase 2 certification. Some of you may have gone out of your way to look at our website and read our 45-page narrative. I don't know why, but it would make me feel great if you did. I know it could be hard to sort of navigate not knowing exactly what we put in there, but that's actually going to help me know just how is VHT showing up in the community, not just like judging how the narrative was written. Does that seem clear on expectations for this activity? Any questions? Yeah, Paula.
What is question 3 under tribal engagement and collaboration?
So on the table, there is, one of you should have a list of the questions. So we left, there we go. So all of the questions are listed on there for reference.
Okay, that is.
Any other questions?
There's 2. Yeah.
Yes,
I wasn't able to stay on the line, but I know that at the VHT board meeting, you did discuss the sector-based approach policy, and it might be helpful as we move into this conversation to have a little bit better awareness of what that discussion contained, because I think it might actually inform some of the community engagement areas of deficiency that you might be seeing, and so it might be feedback that people are giving that you already are starting to
try to address. Right. So it's just maybe something to share, and we could maybe discuss it a little bit later as well. But, so I don't know if you wanted to share a summary or. Yeah, I'm thinking. So I actually would assume there might be a lot of places where folks might say this is a concern, and we might be already doing things to address. So I still want to know what is feeling. What your feelings are. We did at our board meeting institute, so we've talked about having a stronger sector communication policy for all of our board members. So each one is now responsible for a sector. For example, Tony is responsible for public health. And after the last board meeting, he sent out a summary that we compiled as BHT with some key information coming from the Healthcare Authority, key updates on what BHT is doing, as well as all of our next upcoming meetings that folks could join in on. And we've asked all of the board members to include sort of a personal note and reflection about how the board meeting went, or what's the key thing that they want to communicate out to folks in their sector. That launched just last week, so the first emails went out on Friday or Monday from our board members, and I was excited that went pretty smoothly. So we're hoping that that's going to address some of that communication gap there. So that's one example of something we've already implemented in response to these comments. There may be other examples. I'm going to be floating around for all this. So at any point in time you want to say, what's BHT up to? Please raise your hand and we can come over and make a comment. We are on a super time crunch, as usual. So I will have to cut you off around what time is it? 10:45, 10:50. And if you feel like you're, yes?
For a point of reference, I know what an ITU is, but I really doubt that most people in the room know that it's Indian Tribal Indian Clinic.
Can you use the mic?
No. So for those of you who are unfamiliar with Indian healthcare, ITU refers to Indian, which is IHS, Indian Health Services. Tribal, it's a Tribal 638 compacted clinic like ours, and Urban is the Native Project.
Thank you, Ron. I've lost a point in acronyms and jargon today. All right, so unless there are any other questions, I think I'm going to just kick this off. I'm hoping that this can mostly be small group discussions, and then we'll be eager to collect these at the end. And at the next Leadership Council meeting, I hope to have a report out on sort of what we've learned and how we'll be incorporating these comments into the next round of our application. And I'll give some friendly comments of, hey, it's probably time to move on to the next section to keep us all on track. And with that, everybody break. Thank you so much.
And for the folks on the phone, this is Devin. If you have any questions about any of the deficiencies that are listed or any general BHT related questions as well, I'm happy to answer those concerns while you're going through the SurveyMonkey, which the link should have been placed. It has been placed in your chat box. And if you can't see that, just let me know.
So anytime in the next week that you can throw those into the SurveyMonkey, we'll absolutely take them. So sorry, I know we never get as much time as I want for these discussions, but also nobody wants to come to 4-hour meetings with BHG, I think. All right, so with that, oh, Justin, can you click the screen part for me? There we go. Okay. With that, we are moving into some very exciting conversations about making some decisions and also how money is flowing for now that we actually have some money. And to start this off, we want to tee up a quick conversation about the project selection. So by November, we have to tell the healthcare authority how many projects and which projects we want to take on for demonstration. We're required to do at least 4. Opioids and bidirectional integration are required. We have to pick at least 2 other projects, 1 from each domain, but we could do all 8 if we wanted to. BHG has been going back and forth a ton about what feels the best fit for us. So today, Jenny's going to come up and sort of give a quick little high-level overview of what it is that we're thinking on how we're approaching this decision. On your table, you have a piece of paper here that is available for you to leave any sort of comments, questions, or this would be helpful for me to know in order to make an informed decision or figure out what's best for me or my organization. And next week on Wednesday, we're going to host a webinar phone call that's going to be a deeper dive discussion, sort of open into how we're approaching this and we're really looking for feedback from you all on how many projects feels like the right fit for BHG. So I'm frustrated that we don't get to have like a big conversation about this today, but I'm hoping that with hearing the overview, you can give us some feedback on these forums that'll help us make a really informative and useful webinar on Wednesday. We'll record that and make it public so everyone will be able to listen to the conversations that happen. And with that, I'm going to hand it over to Jenny. Here's your clicker.
Thank you. Hello. So we're just going to go through. Hadley didn't. She said we're on a tight deadline. We got to get through other information. So, like she said, we hope to cover a lot more in the webinar and future learning sessions that we have planned. There you go. So the demonstration project decisions that we have to make, performance measurements is a large part of the Medicaid demonstration and are tied directly to our region earning funds. The goal of today, to give you a really brief overview, and the webinar is to help the region form and give you a really good sense of where we are as far as measurements that are tied to all of these projects and how our region will earn funds, give you a sense of where we are and how many projects we are, and I'll go through that. So we have 3 different ways that our region earns money, funds: planning, reporting, and performance. These are kind of what we describe as 3 different buckets that the projects will flow through our region into. The first one is keeping at the ACH regional level, paying out to collaboratives. I don't know if a lot of you have heard of our collaborative forming discussions that we're having. And then the third is paying out to other partners. And we'll break this down in a couple of different slides here. So keeping it at the ACH level, we would have a few more buckets, the sub-buckets that we would put the funds into. 15% into a contingency fund, 10% into a community resiliency fund, district projects running out. So that would, as an example, would be the hub, district management, project management, and admin costs, and infrastructure investment. So health information, technology, workforce, sustainability. Payment to the collaboratives would be performance and reporting type of actions would generate payments to the collaboratives, and this breaks down how that would happen. So the state that we are at right now is we really need to decide as a region, does our project that we're putting forward, which is due November 16th, is it going to include 6 or up to 8 projects? So 4 obviously are required within the project plan, and then 4 are optional. And what we're finding is that there are a few of the projects measurements that that go across other types of projects, but there are a couple specifically that we'll look at that only have their measurements tied directly to that project. One of them is maternal and child health. If we, as an example, we could do up to 8 projects. We are currently posing a question of, does it look like 6 projects or 8 projects? So if we were to do 8 projects, the project weight tied to that metric, those set of metrics, is 5%. Estimated over the 5-year period is $4.5 million. The expectations, approaches, and strategies that we would take are highlighted down below, and then the next slide specifically spells out the metrics as far as what our region is going to be expected to attain. In demonstration year 3 to 5, it's pay for reporting, so it's getting the plan in place, following the plan, reporting as far as, yes, we did this, the region is here. And then towards the end of 3 years, of the 3rd year, our region would be earning funds for pay for performance type. So our region is actually putting this in place, and here is the performance that we're generating. We're moving the dial. Oral health, on the other hand, also is another project that we're looking at. The whole set of metrics tied to that, it really only affects those projects. Expectations again, strategies. So that would be, the project weight in itself would be 3% spread across an 8 project plan. Estimated funding is $2.7 million. And again, the oral health measures, reporting time frame of what it's looking like. Couple of the paper performance highlights here are dental sealants for children, opening access to dental health for adults. So, as you know, we went through a process earlier this year of asking for letters of interest as it relates to the optional projects. And just very briefly, these are some of the proposals that we got from our partners. There were 6 that specifically called out, wanted to do some type of maternal and child health program. There are 6 total. And then these from our health system inventory is what were initially indicated interest. Either they're currently doing it or they have an interest in doing these types of projects. Bright Futures, definitely currently being utilized and open to adopting. And then also long-acting reversible contraceptive, and the one key question as it relates to Oral health, for the letters of interest, we received 8 that are specific to that project, those projects. Mainly focuses around sealants, providing access. And then the health system inventory. We have quite a few clinics that are willing to adopt a varnish into their primary care practice. And then interest in the dental residency clinic. One thing that we wanted to note was that there wasn't any real interest in the mobile dental unit for our region. So this really gets us to the question of if we determine that the MCH and the oral health should further be considered in our region, these are some of the questions that we're posing to ourselves and our partners. And we're really wanting to generate some discussion around the measurements. On the webinar call that we're going to host next week, we'll be given some very unofficial data as far as where our region stands with those metrics and where the state is right now as a whole. Any addition? Question?
Sorry, do we have access to these slides on your website?
Yes, we'll be sending out these slides along with that data and the metrics with the webinar information and how to connect next week.
On this forum, will the webinar be on Monday the 2nd or Wednesday the 4th?
It'll be October.
Was that my bad? Are you sure October's not the 1st?
First is Sunday.
The 1st is Sunday?
Oh, the 2nd.
That's my bad. I probably read September. Our intent is Wednesday the 4th. Yes.
Okay.
All right. Thank you, Jenny. So like Jenny mentioned, so I'm going to send out today and also a recap in the notes of tomorrow's meeting, an invite to this webinar, so you have the registration link. We're going to send out these slides, but also an expanded slide deck that includes the overview you saw of those projects for each of the 8 projects, as well as a slide that includes some unofficial baselines of how we're doing right now as a region. So we've been working with folks at Providence Core who pull all sorts of publicly available data to see how we're doing, so that when we have this discussion, we can actually see sort of where are we today and have a really informed discussion about the region's readiness and viability for different projects. So I'm hoping that if you are interested in attending this webinar, you have some time ahead of time to dive into those slides and sort of explore the metrics and the models. So when we come to that discussion, we can hopefully have some really good, get some really good conversation with you all about your opinions on the different project options. Yeah.
So are we going to, sorry, I'm trying to think how to frame this. So are we going to get this information that we're asking for? Sorry. No, are we going to get the information that we're asking for on this sheet of paper prior to the webinar so that we can review it and then come with a discussion, or?
We're going to do our best. So everything that you put on the papers, we're going to read through those and try to either make sure that it's available in our presentation, so that we thought, oh, okay, this would be useful for folks in thinking about this. We can tweak our presentation to match that. Or if there's anywhere where you're asking for information, we'll do our best to make sure that gets out as soon as possible. As you know, and I've appreciated your grace, we do everything really fast-paced here, so I'll do my absolute best to make sure we can get you whatever would be useful. Does that feel okay? All right. Thank you all for working with this. And with that, we have, I will pause. I just maybe want to pause for like 1 minute to make sure if anyone did have reflections that they wanted to write down, they got a chance. So I'm going to stand here awkwardly for 30 seconds while you all write. Yes, Jenny?
I have a question, and I hope I don't sound like an idiot. But just looking over this slide, the discussion on 6 versus 8, I mean, just looking at all of this, if these truly are the questions that are being asked when you're deciding which projects to fund and whatnot, I'm seeing things like high magnitude of documented need, large number of Medicaid covered lives, and I do see the engage across the region, but I guess I have a concern coming from a rural county and the rural areas if the large number of lives, meaning urban, is going to outweigh those in the rural communities. And so that, I mean, that's a huge question I have as, you know, we are participating in this as well.
Yeah, that is we've thought about that a lot, and if you hand that mic to Allison.
So I think it's important to think about all of these as sort of data points in this decision making. We're not saying that any of these sort of trump any other area. I think one of the, when we're thinking about impact and how these dollars would flow, we're going to be measured on the entire region. So if I could just hypothetically say that Pend Oreille is really interested in this particular project, but nobody else in the region is, it's going to be hard to have population level impact in that way. Conversely, it is possible that in the urban area, we identify these are projects that really are more urban centric. And Pend Oreille says, doesn't really work for us because we actually don't have that many babies being born or whatever, and you would opt out of that. So I think there is a little bit of unfairness. I'd like to just call it like it is. Like, these dollars are earned by the region based on the 197,000 Medicaid lives. Why we think that the two sets, oral health and maternal and child health, are optional for us to talk about, I think will allow for some of that geographic difference, and why the 6 that we're saying, even though there's elements of being optional in them, are actually required, because the region can't meet those targets without doing that activity. But I think it is important to note that as we roll out our collaboratives, which will be the primary mechanism with which the dollars from the waiver will flow, that there will be a set of must-dos and then a set of, if you are interested in, the must-dos gets this amount of funding, it would be interesting to innovate in this way gets a different bucket of funding. So the more you do, the more potential you have to earn more. And we're going to have to balance out how do you get population level impact with regions that have small numbers of Medicaid lives.
All right, and I should have mentioned for folks on the phone that the last question on the survey is actually the same question that the folks have on the room. Folks in the room have here to give comments on the webinar, so if you also have things you want us to know, please go ahead and use that survey link. And with that, I'm happy to kick off the last section of our leadership team meeting today. Mark Bukai from School of Providence, and he is our region's representative on the value-based payments task force that the Healthcare Authority has assembled. So he's going to be here today to give us an update on the VBP work and how it's going along. Here's your clicker.
Thank you. Good morning. Morning. Yeah, good morning. Let me drop this down. So, value-based purchasing. So let's start with that. How many people are familiar with value-based purchasing? One. Okay, I'm done. That's not too bad. Second one, how many are familiar with what the Healthcare Authority is thinking about relative to value-based purchasing as well? Okay, this will be pretty easy then, Allison. It won't be too bad. The first one I'd start with is, under the Healthcare Authority, they have a value-based purchasing committee. They call it an MVP committee. MCOs are there, delivery sides are there. A lot are represented for it. Part of the conversation earlier this summer, in regards to what we would look at, and this is going to be from a philosophic approach to this. So I'll just say right now, the question at the end is going to be, what's the term and condition look like for a contractual arrangement? It's not going to occur today, but we can give some examples of what some value-based arrangements would look like. But the conversation started with the Healthcare Authority to try to do sort of an assessment of what's going on and what's the readiness for providers in this arena. And they compilated some of the information and came back to us in September and shared it. And we kept it like this in draft because we have not had a follow-up meeting in regards to it. So what we'll present is actually what's coming from those that are participating with the Healthcare Authority in this space. We're not, they have this, they have the PowerPoint in their materials?
We will be releasing after the meeting. Everyone will get it.
Okay, so since you don't have it yet, it's going to be a relatively dense deck. We're not going to go through all of it. I'll just outline some items for you so when you are looking at it on your own time, you'll understand the way it's formatted for this. So in this particular one, again, we're not going to touch on everything, but we go back to this. We go back to the second bullet item. What is the provider's understanding and core capabilities to succeed in this area? This is where a lot of conversation is occurring. Because as you referenced about urban and rural, there's a lot of questions about small independent practices or rural practices that have no or minimal resources to be able to be prepared to go into the value-based world. We'll show you a little bit, a landscape document in a second, but just keep in your mind right now, we're in a predominantly fee-for-service world, right? We're in a volume-driven world. You come to see someone, you come to see a physician, or you go to the hospital, or you receive some traditional core medical service, charges drop, contractual allowance is done, payment is rendered. Doesn't matter if you liked it, if you had a good outcome, if you had a complication, payment is rendered for this. This whole push is to move into the value-based side. So what is the readiness of the providers to be able to enter into this? And the timeline is finite. It's not open-ended. There's a requirement that we need to do it. And so there's a lot of debate about whether the provider and delivery side is ready for it. If they're not, where are they going to get the resources to be able to get ready for this? And just to finish that type of conversation, we spun into what's the role of the ACH to help the providers get ready for this. We haven't landed on that, but know that that was a lot of dialogue as well. This framework, this document, I mean, this single page is probably what you need to recall most. If you don't have time to go through the whole deck, go to this right here. People are familiar with this, have seen this before, should see it before, because the Healthcare Authority is adopting this as their roadmap to value-based payments. And they're mimicking this off of what was put into play for the provider community in Medicare. This is for Medicaid, but they're adopting this for what's happening right now in 2017, which is the reporting period, the data gathering period for fee-for-service Medicare, so that payment rendered in 2019 for Medicare will be across these categories here as they move from the fee-for-service into the population-based payment. The good news is for the providers, for the provider community, we don't have to have a roadmap for Medicare and a roadmap for Medicaid. It's one and the same. It's good news. The bad news is we're right over here with some in category 2. So we already talked about fee-for-service where we are. It's not linked to any quality or value. Service rendered, payment provided, done. You move over here to category 2, and it's not taking the big leap yet, but they're saying we need to help migrate the ability and the capabilities to move to the right. And so we're still going to provide a fee-for-service, but we're going to introduce a quality and a value component for that. So what's that look like? If a normal physician visit is $120 and you got a write-off for that, you get X amount of dollars, that's the fee-for-service. The quality piece, they start tying into performance metrics that they will begin to gather data on. Hemoglobin A1C, mammograms, immunizations, whatever it may be. Patient satisfaction for it as well. If that's the case, the provider would get the fee-for-service amount, and then there's a dollar amount associated with these quality and incentive payments. Not bad. Upside only. No downside yet. Until you get down here to category 2D. At some point in time, you're receiving these incentive payments that you're going to then have to be able to perform to. If meeting the target is a par level and you exceed it, you get the incentive. If you don't, then there has to be a penalty someplace along the way. introduced to the provider community. Keeps their skin in the game. So that's down here at the bottom for rewards and penalties for performance. You keep on moving over to the right in category 3, and now the APM stands for alternative payment model. It has a little bit of fee-for-service built into this, but the alternative payment model could look something like a bundle payment, an episodic type payment. We used the example at the Finance Committee 2 weeks ago, something like that, like a total hip replacement. Everyone has their hand out for services that they're rendering. In a bundle approach, a singular payment is rendered for something 30 days prior to a hospitalization, so it could be labs, orthopedists, imaging, pharmacy, whatever it may be, the inpatient stay, and then up to 60 or 90 days post-acute discharge. A singular payment, then payment distributed from that single dollar amount. So there's a ceiling on it, an alternative payment. Let's just say, don't quote me on the number, if the total replacement is $40,000 all in for the facility side and all of the provider side and the ancillary and diagnostics. If in aggregate the dollar amount comes in at $38,000, you already had a payment of $40,000, you can distribute the incentive pieces as you wish to those that are involved in this episode of care. If it comes in at greater than $40,000, you already have a contractual amount that you received. You're eating that as a penalty for not meeting what you contracted for. Example of alternative payment. It's not the only one, but there's others as well. The big one is where everyone wants to go to, including the healthcare authorities on to the right, is population health-based payment. This could look like you get one payment for a defined group of individuals at the beginning of their benefit year. You take care of them for whatever may come up. Simple cold, some trauma, some other thing for that. The other would be a percentage of what the total premium they are paying on a monthly basis that you would get. Same approach. You take care of all of their care for it. It doesn't matter. It's a population health approach for it. But know that the healthcare authority in the far right, their definition of this is they like all the stuff at the top, but they're going from 2C all the way over to 4B for this. That's the migration. So if it is this year 1, year 2, year 3, year 4, and year 5, the answer is no. Yeah.
So ACOs are considered alternative payment models, correct?
They can be, yes.
So ACOs would fall into the 3 category?
Would be category 3. So the ACO for accountable care organizations, some of those are federal. A lot of those are dying off right now. The underpinnings of accountable care, take the O off, not the accountable care organization, the foundational principles fall under the alternative payment model that you're referencing. Make sense? Sort of? This is what they're adopting. So just know 2C to 4B is where it's headed to. This is just a reminder of where everything is going. So like I said, it's not going year 1 and fee-for-service and population-based payment up until year 5, but know at year 5, we all know that 90% has to be in a value-based arrangement. That's the goal. That's the timeline that everyone is shooting for. So now we're working backwards from here. And how do we get prepared to get up to 2022 of 90% of our payment in a value-based world? We had the discussion with some other provider organizations about where they are on that continuum. Again, most of them are on that fee-for-service, dabbling in those value on the upside. Not a lot in the ACO side for it, and certainly not in the population health world. So now we know in a few years we're going to be at 90%. This one, I can't see this close up. The only one I could see on this would be, again, what's the readiness of the providers to be able to do it? We don't have system and structures in play to be able to measure ourselves. Right? Our revenue cycle is on a unit or service that we do. Now you're starting to talk about grabbing data on quality and satisfaction to be able to portray so you can get some payment on. It's not there. We don't have a lot. It's mostly embedded in the legacy model. We need to get into the new world. This This component of it is what the healthcare authority and that MVP group feels is needed to meet the intent for a value-based purchasing. So when you get this deck, the rest of this presentation is going to be based upon these 5 categories. So it starts here, they go to governance and organization, and what's underneath of that as a definition is going to be needed. You can see from provider engagement all the way over, which everyone's excited about, which is the link to social determinant of health. Everyone has talked about for years housing, education, food deserts, things of that nature for it. But the initial thought was, what's the percentage of impact of those in core physical health and core behavioral mental health for it? We're now saying that those items attribute 40% to the total health and well-being of an individual. So not addressing that, we're missing a huge component of it. So when you look at this, it now goes into underneath of the categories that we talked about, the 2B to the 4A pieces. They begin to weight what the importance is of governance within a fee-for-service. Now you get over here into fee-for-service with some incentive payment and upside. Of those 5 categories, they think these are the most important. You get into the alternative payment model or go into category 3 of those 5, there it is, and obviously all of them for population health management. What was the weighting and formula for it? I can't remember, but it was just something that they wanted to do.
What is your definition of provider engagement?
Yeah, that's a good question. So culturally, there are providers in the room before I offend anybody? Okay. I just had this conversation yesterday with an MCO group for it. Would be how everyone wants to talk about how do we address social determinants of health, how do we link with our community-based agencies that's not part of our tax ID or our core service function for it. But the way we're reimbursed and the way we compensate our providers, at least in our organization, has a disconnect. We're talking about value here, and we're paying them on volume. So to get the culture change from at least our provider community to move to the right, we have to switch that up. Now, saying that, I'm not saying that we just switch the employment contract that's going to make that happen. But it has to have the greater understanding in the physical world, which the functional integration of managed care for behavioral mental health bidirectionally with physical is huge for it, and the social determinants, because they've only been treating in the physical world. If I said that 40% of the total health and well-being could be attributed to social determinants, we're estimating somewhere between 25 and 30% in the physical world is being wasted because we're treating them physically when they have an underlying behavioral mental health issue. So provider engagement is engagement of, you have back pain, I'm not going to send you to radiology to get a CT scan. You need to begin doing some short, those DS, the short form, SF, whatever, looking to see if they have depression and some other items like that before they start sending them off for expensive diagnostics. So the engagement piece, looking at it as whole person versus a symptom, is a big piece. I would say for you, for the rest of this deck, it talks about what are the other items underneath of those 5 categories. So if we had governance and organization and provider engagement and think social determinants, the rest of that is for your read, and it allows you to have just a little greater depth of understanding of what's underneath of those major categories. So what are we saying with this? We have another value-based purchasing meeting coming up. This will be reviewed for. I should say as well that there's some MCOs in the room as well. So there was an MCO survey that was sent out from this value-based purchasing group in July. And so we reviewed those results, and it was in aggregate, not by each MCO, of what is their view of moving into the value-based world. There are 5 MCOs. What's their view? What's it going to take? All that. That was followed up with a survey to the provider community of their view of value-based purchasing. What's their readiness? How much are they willing to go at risk, et cetera? You can imagine that the view of the MCOs of where they want to go with value-based purchasing and where the provider community is on the current state is a big gap. There's some across the state that are saying they're going to move to value-based purchasing at a pace of 0% over 5 years. Some say they don't want to go more at risk than 10% at the end of the 5-year period of time. That's an issue because if I go back to category 2, where it's fee-for-service with an upside incentive quality payment, but in year 5 you have to have 90% in value-based payment, our provider community is not ready for where we need to go according to what's going on with the waiver. Questions? Yes?
How much would be the partnership with community-based organizations?
I'm sorry?
In shifting toward value-based payment, how much would be partnership with community-based organizations?
Yeah, so I'm not going to steal Allison's thunder on this, but the whole approach on the funding distribution away from the Leadership Council, which is the finance and distribution work group or something like that, I can't remember where any of that was, would be to look at more community collaboratives, and I think definition for that to follow. But the more community collaboration we can get, I think it's going to be better for everyone. And I'll just give you my perspective from our Providence side. We're large, but we don't own every aspect of the continuum. And even if we did, we probably don't have competencies in some aspects of the continuum. Others that have their core mission is on that, that's where we need to partner and align with.
I would just add that as we have been thinking about this in sort of the overarching frame, you remember our slide that talks about 80% of your health not being determined by your health care. And while I think we have an incredibly engaged provider community, right now they're not paid based on are you getting healthier. In this model, that are you getting healthier? So we like to joke about right now if you're a Medicaid patient and diagnosed with diabetes, you might get a photocopied piece of paper of all sorts of diabetes management programs that are available. In a new model, community-based services, in a new model, after you've been diagnosed, you might walk down the hallway and somebody schedules you in that program. So I think that's the coordination piece that, one, we're not even saying is really an option as we move into these waiver discussions, because we do think that's the link. And it's going to be awfully difficult to actually improve health if our social services component of this is not equally moving in that way. And because I'm going to just channel my inner Tony Smith, we have to continue to look at the public policy side of this that really promotes at a population level that piece. So there's both the community service side, but we cannot lose sight of the system portion of this as well. Did I do pretty well?
So our provider can, let's take the diabetes example one more time. This is true, and the providers can attest to this too. We measure our providers on diabetic management, right? It's always in the top 3 anyway. So a provider said, I just can't understand why my patient is non-compliant when I'm giving them explicit directions on what to do with their diabetic management and control for. What they don't realize is that they have a choice to make once they leave their office. Are they going to manage that, or are they going to try to figure out where they're going to eat next, or what's going to happen in their home? And when you start talking to the providers about that impact, that category onto the far right side for it, it is going to impact diabetes if we can have social services and agencies being able to address that. But right now, I'll be critical of ourselves. We're looking at it from right here in this lens versus what's available to us in our greater community. And that's what we need to do on the collaboration piece.
And
yes, sir.
In the change management, this in the change management portion, how much of the change for physicians and clinicians is related to workflow compared to, I'll call it how they traditionally provided care or taking care of the person, and in the end, are they, in other models, have they become happier once they make the transition?
Let's say, in the more evolved practices that have wraparound services where the provider relinquishes complete and total control. They're still the captain of the ship, but they can have pharmacists wrapped around them, case managers, diabetologists, et cetera. Yeah, the providers are happier because they're working at the top of their license, and they have colleagues that can come in and take care of their patients without them leaving their office to go to someone else's office, which they may not get to. The change management piece comes in relinquishing some of that control for it. But the way this value-based works is going to have these wraparound services like we haven't had before. The reason why we haven't had it before, and shame on us, is because those services were not paid for. And so when you don't have reimbursement for it, you didn't put them into play. Now you have to think about it as an investment because you're not over here again on this fee for service, you're on the value side over there. And that's where value comes in. Yes?
Is there room for private practitioners?
Is there room for private practitioners to also have this wraparound care? I know that Spokane has a vibrant private practitioner sector, and part of why ABCD Medicaid reimbursements were changed is because it was a private-public partnership, and I want to see private practitioners, mom and pop shops also have an opportunity to have a person triaging cases and making sure that we are providing this wraparound service.
Yeah.
So we can keep choice.
So in that inventory of readiness on the provider side, there was a lot of debate besides rural, urban, scarce resources there, or independent and employed. And it was for sure called out that large organizations should not de facto be the employment option because there is not resources to be able to get ready for value-based purchasing. The fabric of independent practices need to remain. The question is what are they going to do to get their own practices ready into the value side? And there are some independent practices. There's a 4-person pediatric practice, independent for years. Saying, I don't even know, and she's on the committee. I don't even know what you guys are talking about over here. I just know I see kids. They come into my office. Someone does something in the back office. No, I need to do this. I'm not going to be wanting to become employed, but I need some help with that. And so I think that's the big question of what's going to happen. There's going to be this divide in the road. But yeah, it's going to drive cost up if there's not independent practices within the community.
And before we jump to Kat, we have one question from the phone line. Blake asks, what would value-based purchasing look like for a client enrolled in long-term co-occurring mental health or substance abuse? IOP? I don't actually know what that is. Intensive outpatient treatment, thank you. How is the baseline determined?
Good question. I'm looking at the MCOs because the terms and conditions for that have not been even high level shared in regards to that. But co-occurring, what does that look like?
Mental substance abuse.
I would say if you go to the far right side, where it's a population health management or an APM side, that the way that the clauses are on the quality and the incentive piece, that fits in there nicely because it's better than the ICU or prolonged stages in some other place. Over here on the fee for service in category 2B, I'm not sure.
Oh, yeah.
I think also in following up to that specific question, the idea of something that's happening in other states is they're actually creating specific behavioral health related bundles. So if you think about sitting in category 3, the idea of disease specific bundled payments that actually focus on certain diagnoses, whether it be around schizophrenia or anxiety or those sorts of things. So Tennessee is one of the states, and I believe Massachusetts and New York are putting bundles together for behavioral health. But I think the answer around sort of the category 4 is where there's actually more flexibility, and there's also behavioral health value-based payment is actually in a relatively nascent state across the country. The comment that I was going to make prior to that question is the slide that has, could we go back to the slide that has the category in the, one more, back that way. There. I think what is important for us to connect this to the demonstration, Mark, I think you did a great job at providing this overview, so thank you for representing this. One of the disconnects that I've seen just across the state, and I think the healthcare authority is recognizing this gap and is trying to address it, is the idea of how we can connect the way in which projects are related to the capacity development within providers as we move across the 5 years of the demonstration. So if we think about that sustainability of the demonstration being squarely based in value-based payment, sort of maintenance of, as we move forward, that idea of how we partner the investments that are coming forward over these years into the capacity gaps that we see within providers, and provider I'm saying in a broad terminology, so not just clinical medical providers. But I think that that's really critically important. So as we're thinking about the way in which the collaboratives are moving forward, how might those collaboratives start to think about how assessing themselves along these capacity areas or domains, and then trying to pull forward where investment can come down through the different project areas. Workforce development, IT capacity, so the population health management, the elements that are within domain 1, those should cut across all of the project areas, and everybody should be thinking about how they could build out that investment, whether it be a regional approach or individually within your own practice.
Your point's a great one in that we have an antiquated model that's not working going forward. This is transformational opportunity, and as we talked about in the Finance Committee, it's not a 5-year project, right? It's a 5-year window for transformation that's sustainable after that. And, you know, putting these new models of care, particularly on the right side, you know, to unwind that would be it's going to be difficult getting there. It's going to be painful to unwind it if it's delivering a better service.
All right, and with that, I do want to wrap us up. We committed to ending this meeting early because we heard that a lot of folks were planning to attend the Women of Achievement luncheon, and we just sort of figured, all right, we'll give you all half an hour time, and if you want to attend that, you will not have to feel bad about standing up and leaving in the middle of the meeting. I do have one last request. So as you can see, I'm going to grab that from you. Thank you, Mark. We are testing out the rounds and trying to get some more options for us to be able to deliver a lot of content here, but not spend too much time on discussion, because unfortunately it's just like really hard for us to balance that. Like, how do we make sure we have really good time to hear input from you all and have good activity and discussion, but also make sure we get you the information that we want to share. So I would love we're going to start a standard practice of at the end of every meeting, we leave a stack of note cards on the table. And if anyone is, as they're walking out the door, you're stuck, there's like one question that's just burning where you're like, man, I really don't get that, or I'm confused, or I wish that I knew more, write that question on the note card, and we'll review them so that we can be knowing, like we can do a pulse check, and at the next meeting, if we need to, we can touch base on those questions. And then on the other side of the card, we're asking if you can just leave us one note. Maybe it's a thing that you want BHT to remember. Maybe it's something that was said in here that you want to make sure that we are holding in our work. Maybe it's a comment on, I would appreciate comments on how this meeting felt. Like if you thought the activity was useful, that this was a good flow. That's really helpful for me and how I shape these meetings. So I'm just looking for anything you got. And with that, thank you all for coming. I'm not going to the Women of Achievement Luncheon, so I'm going to hang out here until noon. And if anyone would like to continue mingling and taking advantage of the space that we're all sharing together, please feel free to stay here until noon and chit-chat amongst yourselves or with BHT staff. Thank you so much, and we are closing us out. Happy Thursday.
Thanks, Abby.